Welcome to the Experts in Sport podcast, brought to you by the School of Sport, Exercise and Health Sciences at Loughborough University. As part of our Lifestyle for Health and Wellbeing series, I spoke with Professor Paula Griffiths and Professor Emily Rousham from Loughborough University, and their international partners, Dr. Elizabeth Kimani-Murage from the African Population and Health Research Centre, and Rossina Pareja from the Institute for Nutrition Research in Peru. We discussed their research and its impacts on global health. So, hi everyone, thanks for joining me on the podcast.
Hi Martin.
So, we're going to talk about your research and its impact on health around the world. We're going to discuss the background to your research. We're going to focus on some of the health and nutrition challenges that low and middle income countries experience and where this has led your research. We're then going to take some of your international partners. We're going to take a specific look at recent projects in Kenya and Peru, the impact of this research, and how your work with the World Health Organization has helped to inform policy. But before we get into those case studies, can you give us a bit of a background into what you do in your research and why it's important?
Yeah, sure, Martin. It's Paula here. Yeah, we do this research really because the answers to these questions ought to be simple. So what Emily and I do with our partners is we try to improve health and nutrition of infants and young children around the globe, and the challenges are different in different parts of the globe. But in the countries where we work, undernutrition remains a problem, as well as overnutrition becoming a developing problem. And it ought to be simple, really, to help all children to survive to the age of 5. There's no reason why every child or most children shouldn't survive until the age of 5. But unfortunately, at the moment, a lot of children still don't survive to the age of 5. And undernutrition is a big problem that's related to that. So there's research that's published that shows that undernutrition is associated with about 45% of deaths in children under 5 globally. So if we can do research that improves children's nutrition, then we can go a long way to improving health and mortality. And I think it's probably fair to say that we're not only interested in helping children to survive, we're also interested in helping children to thrive. And optimal and good nutrition is also an important part of that, helping children to thrive and grow and develop well in their early years. So that's why we do the research. We're trying to achieve that goal and improve that situation.
And I'm going to make it difficult for you now. I'm going to put you on the spot with, have we got kind of numbers around this? So like, the children surviving until the age of 5, like how, what are those rates potentially in the UK, or what are they in the world? Do we know any of those broad figures?
So just to give you an idea of the scale of the problem, Martin, there's still around 5 million, in fact, just over 5 million children under 5 die each year globally. And that's probably too big a number for anyone to even to imagine. But if you bring it down to the daily amount, it's just under 14,000 children die a day. And we're in a school of sport, exercise and health sciences. So I feel like we should have a sport analogy here. If we look at our local rugby stadium, the Leicester Tigers rugby stadium, its capacity, if we fill the capacity of that stadium with under 5s, then every 2 days we would lose every child seated in that stadium. And most of those deaths are preventable. So I think that gives you a good idea of why we would want to do this research. These are our future, these children under 5. And so any research that we do that can improve the survival and the health and well-being of these children is, the future of society. So that's why we do what we do. Yes.
A very humbling stat. I mean, I asked the question because I thought it might be something that might, really engage the audience, but I mean, that's probably going to engage and shock a lot of people. So thank you for showing us the depth of the problem here. So obviously, I mean, there's obvious reasons why you do this research. Is there anything that got you into this research in the first place?
So for me personally, I think it probably started in childhood with my parents telling me about stories that they have about food security from growing up in large families without much resource. So from an early stage, I was aware that there are children that don't get enough to eat. And then I was really inspired when I went on a family holiday actually to Kenya, as I graduated from university, and saw that problem remained today. Because I think until that point, I thought that there was something in history from living in the UK and the experiences I had growing up in the UK, and saw that there were children in Kenya who weren't getting enough to eat, and thinking, well, why is that? as a young adult, why are there still children who don't get enough to eat? And so that kind of inspired me to want to to do research, to understand that problem better and to think about solutions to the problem. But Emily, you may have different things that have inspired you, I think.
Similar and slightly different, but I came to this really from an academic point of view, first of all, because after my degree, I wanted to study for a PhD, and I jumped straight into a PhD that involved working in Bangladesh. So I lived in Bangladesh for nearly 2 years in a quite remote village, and there were multiple challenges around nutrition at that time, and I sort of saw the whole annual cycle of living in a rural area and growing up, and the harvests and the harvest failures and what happens when there are food shortages. So it was that first-hand experience that sort of stayed with me, and I've worked in that area broadly ever since in different countries.
So Emily, you mentioned Bangladesh there. What other countries are there that yourself and Paula have been working on?
Paula's worked a lot in Kenya. We've had projects in Ghana, which Liz was also involved in, South Africa, and more recently I've worked in Peru, and so has Paula.
Yeah, and I'm currently working in Mali as well.
So for those who are interested in listening, to find out more depth, you can go and see Paula and Emily's profiles, and we'll put some links in the press release we put out with this. So there's lots of research around the world, but today we're going to focus upon two case studies really, and we're going to start looking at Kenya. So we're going to say hello to Liz. So Liz, welcome onto the podcast.
Thank you so much.
No worries. It's great to have international partners because it's okay for us to talk about the research, but really demonstrating the collaborative approach that you guys have all taken to this. It's brilliant having you on. So thank you. We're all sat here. So we're in the UK, and we've got yourself. I think, are you in Kenya right now?
Yes, I'm in Nairobi.
Nairobi right now. And then we're going to speak to Rossina in a moment, who's currently, I think, in Lima in Peru. So it's pretty cool with now we're all on Microsoft Teams and we can do this kind of thing. It's really, really great to get everybody's insights because I don't think you'd be coming to Loughborough for a half an hour chat, to be honest. Let's get into it. Let's get started with the research in Kenya. So, Paula, can you tell us a little bit more about kind of what your research is and how it started?
Yeah, so Liz and I have actually been working in partnership. Liz is at the African Population and Health Research Centre now for over a decade in Kenya. She oversees the health and wellbeing team at the African Population Health and Research Centre, and she leads and is the head of nutrition and food systems unit there. And we started actually in a collaboration on a training fellowship that Liz was awarded, a prestigious training fellowship from the Wellcome Trust, to better understand how to increase and improve knowledge of maternal, infant, young child feeding practices in urban poor areas in Kenya. So we started working on that project, and that project was very much about trying to improve knowledge amongst the women living in those areas, to give them the information that they would need to feed their children and infants well in the first 3 years of life. I think very soon after we started that project, Liz, correct me if I'm wrong, but we soon learned from the communities that we were working in that it's not enough to give people information, because information is only good if you have the resources to act on the information that you're given. So, for instance, if you tell a family that they should be feeding their infant 5 different food groups in a day, if you live in an environment where there are not 5 different food groups that you can afford to buy in a day, then that information is mute, right? It's not useful to the family. And so I think from there, we started doing more community research and working with communities to understand what they thought the problems were, and to think about solutions that might work for those communities. And that led into a Wellcome Trust International Engagement Fellowship that Liz was awarded, where she's been doing quite a lot of work with communities to talk about how they can come up with solutions to food insecurity within their communities. And one of the concepts that arises out of that is kitchen gardening and having control of your own environment and being able to have resources to grow food collectively as a community, to improve the resources that are available to the community. But alongside that, we still were aware that the intervention that we had been collaborating on in the slums of Nairobi with the education component, that it mapped very well onto what the Kenyan government was currently trying to achieve, which was to roll out a national program of giving more information to mothers of infants and young children, to improve their infant and young child feeding practices, because you still need knowledge. Even if you improve resources, you need the knowledge of what you need to feed infants and young children. And so we became involved in another project, which was actually funded by the US government, but working in partnership with the Kenyan Ministry of Health, surrounding the Baby Friendly Community Initiative in Kenya, which builds on an earlier UNICEF and WHO initiative in hospitals to try and improve breastfeeding, but to bring breastfeeding now into the community and knowledge and resources to support breastfeeding, including mother support groups and community support groups to kind of advocate and support women in breastfeeding and early infant feeding. So we did a trial together to produce the evidence for that kind of program. And we showed in that trial that we could improve breastfeeding rates quite significantly, actually, in rural areas. In the communities we were working, the breastfeeding rates went up from 43% to 87% in that trial. So quite a significant improvement. So I think I could talk a long time about what we've been doing, but that's probably a quick summary of some of the more major projects that we've worked on together in this area. But Liz might want to add some more to that.
Yeah, it sounds like a great summary of 10 years of work. Liz, do you want to come in and just let us know kind of what issues were there happening when some of this research first began? So, for example, what were the problems with breastfeeding as an example? And how did you overcome these issues to get such great results?
Yeah, maybe just to clarify first, it's not just breastfeeding, it's exclusive breastfeeding. In Kenya and in African countries, breastfeeding, any kind of breastfeeding is high. The prevalence is quite high, but the exclusive breastfeeding is the concern. And in the urban areas where we started working with Paula, these are urban poor settings where women are of very low socioeconomic status, and they have to really look for food. I mean, they have to go looking for food for their families, and so they shortly after giving birth, they have to go look for work to be able to feed their families, and that's now the problem with exclusive breastfeeding, because exclusive breastfeeding, you need to be there, and since they work in places which don't they are like casually employed, so they leave their babies behind, because they don't have maternity leave like people employed in formal employment, and so they have to go look for work and leave the babies behind. And so and because of the situation in their communities, the sanitation, the hygiene issues, and they don't have fridge and all that, they are not like empowered to express their milk and leave behind for the baby, and so they leave their babies with other food other than breast milk. So that is in the context of urban poor settings. But so in urban poor settings, we are actually talking about exclusive breastfeeding of 2%. And with the work we did with Paula, the rates went up to slightly over 50%. From the perspective of empowering the community through knowledge, but also supporting the women to be able to breastfeed, and also to express their breast milk and hygienically and all that. But in rural settings, it's not as bad, because the women they don't necessarily work for money, so they work mainly within their compounds, the farm, but still there was a problem. As Paula said, the exclusive breastfeeding at the time we started was at around 43%, and with the intervention went up to about 87%. So there are different challenges, but more challenges with the women in urban poor settings because of having to look for work outside their home.
And just to kind of clarify, What kind of time frame are we talking on that? Like when do mothers actually start to go and look for work and, you know, not be with baby? Like here often, you know, most women now might go for 9 months of maternity leave or supported or a year. Some might be 6 months in the UK. I mean, what are we talking in Kenya?
Okay, so for women who are employed, those are the women who actually benefit from maternity leave, and that happens for 3 months. Usually it's 3 months. So after 3 months, normally you go back to work. But for these kind of women I'm talking about, they are casually employed, and often most of the time they do not get maternity leave. So for those women, they tell us they have to go look for work shortly after, maybe within the sometimes within the first 1 month, or just slightly after 1 month, they have to go look for work, and so they leave their babies behind.
Wow, I'm sure a lot of mothers listening to that will be you know, thinking about that in some depth. But that's really interesting, you know, to me, not being a mother, but I've obviously been around it. I've got 2 kids myself, and yeah, I can imagine probably the heartache for everybody there of, you know, however long you're away for. I mean, I think my wife wouldn't have left our kids for, you know, unless I was there for less than a second, if that kind of thing. So in that first month, it's a really interesting cultural kind of difference, but also the impacts from that are quite clear to see in your research. So you've already mentioned the great impact that the research has had. What is it exactly that you did in this instance to have such an impact?
So the intervention, we worked with the Ministry of Health and other partners to implement the baby-friendly community initiative, like the work that Paula talked about in the rural settings. And the baby-friendly community initiative is a program that is promoted by the World Health Organization and the UNICEF, and of course now adopted by the Ministry of Health in Kenya. And it involves having community health workers being trained on supporting women to be able to educate women on breastfeeding and optimal infant and young child nutrition. And so the community health workers, after being trained, then they go to homes, they visit women at home, they counsel them on breastfeeding, but all over and above counseling the women on breastfeeding and infant and young child feeding, and also feeding for themselves, they also support the women. Like some of the challenges that we had before from women was that they were not able to breastfeed optimally because they had many challenges, like even how they didn't know how to latch the baby optimally. I mean, latch the baby on the breast and position the breast appropriately so that they can breastfeed their babies. And that led to many challenges, like having breast engorgement, engorged breasts, and sore nipples, and that led to health issues, and that also limited their breastfeeding. So being able to, that empowerment of just knowing how to do the breastfeeding optimally also helped. So it's about the counseling and the support, just also that frequent visit, and the community health worker is checking on the woman. Are you still exclusively breastfeeding? Do you have any challenges? How can I help? And so that kind of support was what made a difference.
That's a really important point, the support, because I think that was something we learned so much about in doing these projects. And I'm particularly reminded, Liz, of the rural project where we were talking to the community and the fathers were kind of saying, well, yeah, this nutrition stuff, it's women's stuff, right? Feeding the baby is breastfeeding. It's all about the women. They need to do that bit. We don't do that. We go out and we work. But I think one of the changing moments with the men in the community was when we talked and we connected in another project, the nutrition to the development of the children and their education, because that's more of the men's responsibility to make sure that the children are well educated and do well. And so when the connection was made between breastfeeding, good nutrition in infancy, and doing well in school, that brought the men more on board. And actually the men are really important in this, because whilst it's the women that do the breastfeeding, the men can support the women to be able to do the breastfeeding, by doing other things in the household and just being supportive of breastfeeding in the community. So it really did take the community, the whole community, to support the project and improve the exclusive breastfeeding and the nutrition of the infants and young children, and the community support groups of the Baby Friendly Community Initiative were a big part of that. So there's that old saying that it takes a whole village to raise a child.
Definitely. That's the really interesting piece that I was picking up there, that it does, take the whole village, the whole community to raise a child. And you mentioned, obviously, we're talking about females and parents, but the males have been brought in as well, but also the community worker, as it were, to come and help and kind of bind that all together seemed like a real key element to kind of make this happen. So that's really interesting. And obviously with the numbers you've been kind of putting there, I've just seen the World Health Organization, I think, recommend 90% is the target. Are you getting pretty close to that then? So is that the goal, to try and get to the 90% of people doing exclusive breastfeeding?
That's absolutely the goal. Yes. Yeah. I mean, in the rural areas in the project, we did get very close to that. So that was an amazing outcome. The challenges are harder in the urban areas, as Liz alluded to, with women needing to work to support the families as well. But any improvement towards the 90% is also great impact. It's improving the situation. So 90% is the target, yes. And in Kenya now, Liz might correct me, but last I looked at the stats, it was around 62% nationally, exclusive breastfeeding.
Yeah, about 60 now, yeah. So we are a little bit far, but we are the country that is ahead. And I think we are one of the countries ahead of others, when you look across different countries. But we are still a bit far from the target, but we are kind of like almost on track, while some countries are lagging behind. But it could be that this the Baby Friendly Community Initiative, which is being rolled out in Kenya and has been rolled out in several counties, is helping women. It's really helping women to be able to exclusively breastfeed their babies.
Put in context, in the UK, we're not very good at collecting data anyway on exclusive breastfeeding, but the most recent surveys that are quite out of date now, it put the estimate at kind of less than 5% that achieve exclusive breastfeeding to 6 months. So that puts in perspective where Kenya is and what Kenya has achieved. Yeah.
It's brilliant. What I was just going to say is it's been me, doing a little bit of reading around the research that you guys have done. It's been really interesting to see the impacts of, that you guys are having on global health around the world. So we've talked now about Kenya. We're gonna move on and look at the case study in Peru. So thank you, Emily and Rossina, for sitting nice and patiently there. So Emily, would you like to introduce us to Rossina and just let us know a little bit about your research?
Yes, certainly. Rossina Pareja is a wonderful colleague. We've been working together for around 5 years now. Rossina is senior researcher at the Nutrition Research Institute in Lima, Peru, and we've been working on a project looking at nutrition in the early period of life from 6 months to 24 months of age. And this is known as the complementary feeding period. So it's the time when you start to introduce solid foods after that 6 month period of exclusive breastfeeding. What's interesting in Peru is that there have been some quite significant improvements in health indicators in the last 20 years or so. So a lot of undernutrition has been reduced. But two nutritional challenges that are still really common in Peru are the high prevalence of anemia, and a lot of that is caused by iron deficiency in the diet, and an increasing prevalence they have in Peru of overweight and obesity. So this is common in adults, adolescents, school children, and we think it's going to move down as well to affect very young children in that complementary feeding age. So we had a project, Rossina and I and other investigators at Loughborough and in France and 3 universities in Peru, or 2 other universities and the institute, where we were trying to develop new strategies to tackle these 2 problems of anemia and the risk of overweight and obesity in young children.
So how did you get started with this? So I know, from our discussions, you talked about a co-designed approach to impact the burden of double malnutrition. I think you've touched upon that a little bit there. So how did you come together to kind of look at what you were going to research and how you're going to move it forward?
project came about because actually it was funded by the UK research funders, UKRI, through what they call the Newton Fund, and it was funded by Peruvian funders, and they purposely brought together UK and Peruvian research teams. So we designed the proposal together, and we decided, as well as understanding how common these forms of malnutrition were, what we call the double burden of malnutrition, we would try to then develop strategies to tackle it, rather than us as researchers just coming up with interventions. We wanted to get the caregivers, parents, aunts, uncles or grandmothers, and we wanted to get the healthcare providers to come up with challenges. So Rossina led a lot of this co-design work, so she might be able to tell you more about on the ground how we did that.
Thank you, Emily. Yeah, it has been a really nice experience working with this group of researchers. Actually, at the Institute, we have been, all the time that we have worked with the community, we have conducted formative research in order to understand what other factors are involved in some behaviors and practices. So trying to come up with a better intervention that also take into account the cultural part of the behaviors at the community. But with this experience with Emily and all the circle of research that we have, they introduced this part of the co-design where we have been working with the community, not only bringing our knowledge, but also hearing from them what they think that they could need to do in order to improve some practices, And it has been a challenge because during the process of the conducting the research, we had this pandemic. So we have the challenge to introduce this co-design and work with the stakeholders, and stakeholders we have these two professionals, the community agents, also the mothers, and especially with the health professionals, they had a lot of work with this pandemic and all this workload that they have. But we try to have these meetings with them to come up with, a brainstorm of ideas of how these challenges that we found, like for example the consumption of high sugar, these sugary snacks that the kids had, because we have a baseline evaluation where we found that these kids are receiving a high percentage are receiving these sugary snacks, sugary beverages, and also they have this problem with anemia. We are finding that, as Emily said, this double burden. In a same home, we have a mother with obesity and a child with anemia. And with this practice, that we believe that it will, if they can introduce these habits of having this sugary food. So we come up with this brainstorm of ideas and working with the mothers too. At the beginning, we work with the mothers as a group, and then with the health professionals. But at some point, we got everyone together, and I think that was the most interesting part, because for the health professionals, they start to understand some things behind these practices. Because sometimes in Peru, we feel that we always say the mother, you have to do this, but we don't understand what are this behind these mothers. So I think they had the opportunity to hear the mothers and to try to come up with ideas together. So we developed with this co-design. We ended up with 2 prototypes of strategies trying to help the community to solve this or to point out this important problem with the double burden, and trying to help them with the complementary feeding. So we ended with an app and also with a game, because what we saw is that one of the opportunities that we have is at the health center, when the mothers were waiting for the control with the kids. So they have a space there. So the mother said we could have something to do with the kids while they also are learning, trying to experience with some food and some key messages. So we have this game that it can be used at the health centers, and we are trying to introduce this concept of healthy diet, and also trying to introduce the idea of a good consumption of fruit and vegetables is important for the children, no? And with the app, we try to also help the mothers to get some information, get some recipes that they could use, no, in order to know what kind of food I can use, what combination I can make, and also about anemia, no, because we are still struggling with this high prevalence of anemia in these children, but at the same time, we try to also give information about healthy eating and try to avoid giving these sweet beverages, no? So
It's really interesting. What's really interesting to see is that it's this whole community approach, this educational approach, making sure that all stakeholders are involved. And it seems that we need this. I was going to touch upon this at the end, but we've got other podcasts that we've done that are more UK based, and the solution essentially is the same, that all stakeholders need to be involved, but understanding that local context is clearly what we need to do in any of these situations. So just touching a bit more specifically on Peru, you've talked about the double burden, and you've mentioned having sugary snacks. What kind of things is it that people are consuming, and why are they choosing to consume these things?
Yeah, one of the things, it's interesting because we also conducted a project to understand with this sugary, consumption of beverages and snacks. And what we have found, is that, one practice that is, everywhere in Peru is the consumption of sugary beverages. And this is not only industrialized in Peru, is that the beverages that they produce at home, they make at home, like lemonade, we have chicha morada, which is made with this purple corn, or different kind of beverages, but they add sugar for everything. So these sugary beverages are offered to the children, and also they offer these snacks because sometimes they go outside, so they don't have anything to offer. So instead of choosing like a fruit or a vegetable, they choose to they have these street sellers. So they buy a cookie and they offer to the child. So it's, while they are waiting maybe something, they offer this to the children. Or if they are cooking, they offer a snack, but it's not the best snack to the children. So in general, that is one practice that we have to work in the community. And also we have the National Institute of the National Feeding Institute here also concerned about these practices, no?
And what kind of impact is that having on the health? I know we've obviously mentioned that obesity is rising, but are there other impacts?
Yeah, the thing is, like, in the case of the small children, we are creating habits, no? So these habits of having this taste of for sweet things, we are introducing these sweet things. The kids are eating, and the problem is that these sweet products normally they don't are nutrient dense products, no? It means that they are giving you energy from sugar, but they are not giving you other nutrients. So you are having these two problems. You are giving too much energy, but you are not covering the nutrient requirements. So that is the first thing. Then you have these kids that are growing with this behavior, and they are the tendency as they will have again the consumption of high energy food through life. So now, for example, in Peru, we have around 65% of adults are overweight or obesity. So when we look at where it started at home. It started when the children started to eat, and you teach them to eat, but they didn't get the practice of having, for example, fruit and vegetables. No, in Peru it's very difficult we don't get the 5 portion of fruit and vegetables that is the recommendation, no? And we have also a good percentage of not just obesity, but we have the other non-communicable diseases. No, we have diabetes, we have hypertension. Actually, in this last release of the national DHS, we got for example, for older adults more than 60 years, you have obesity or obesity or diabetes or hypertension is more than 30% of the population of the older adults, no? So you can see that this is also how do you say, a burden of economical burden also for the country, but because these chronic diseases also get needs to get attention at the health center. There are other economical impact on the country, no?
Yeah, this is happening all around the world as well, isn't it? In the UK included, in terms of the obesity side of things. So how have you guys tried to look at making an impact on that? What changes have you tried to do? I know you've talked about the community approach, but has there been any other ways than education? Is that the main way, or is there access to different foods? Is there other issues around this that you've tried to overcome?
I think we have to make a combination, because it's not just the knowledge, but as you said, also the availability of food, that they have the access. And for example, now we are also facing food crisis because of the economical impact in Peru, not just the pandemic, but other political and social crises that we have here. So what we have to try to, at the same time, that's why we want to articulate with other institutions. We are giving some of the bringing this issue of the double burden, and they have to at the health centers or all the stakeholders, they should be aware that even when we have a high prevalence of anemia, we don't have to avoid this other problem of obesity. So you have to try to take these two problems together. And this is also challenging, because the health professionals are or the requirements now is that you should focus on anemia. So we are bringing this thing of, okay, you have to focus on anemia, but don't forget that we are also facing this overweight obesity problem, but also trying to help the community to choose a better food, but also trying to improve the access to healthy food in all the areas. In Peru, we have different regions, different climates, so it's in some areas it's very difficult to have access to all the food that should be there for a good, healthy eating, no?
Emily, did you want to add to that?
Well, Rossina covered it well. I was going to say it's not really exactly about educating it. It's this sort of that subtle change of bringing health professionals and caregivers together, and a sort of change of attitudes or understanding, so that maybe it's not just telling people what they should and shouldn't do, but understanding what stops them from doing what they want to do, and why they are faced with sort of having to choose cheap, affordable, very quick foods, or not being able to store foods or prepare foods. So yeah, it's a bit more understanding on both sides, I think.
And have you had any kind of feedback or kind of impacts of the work so far that you've been doing?
We had a final event with our sort of all our stakeholders together in March, just a couple of months ago, and that was in Lima. That was a very successful event. So we had a whole range of national representatives from the ministries on nutrition and child development, but we also had some of our local healthcare professionals and caregivers who'd been involved in the project over the whole 4 years. And they really valued the work. Sometimes you think you're proving something that everybody knows, but actually they felt there were a lot of new insights that they gained into this by the way we'd approach the work in different ways. And we're still working with them, aren't we, Rossina? So it's not really finished. It's more of an ongoing process. We'd like to continue this and take some of our small co-design prototypes and expand that.
Yeah, and I think one thing that you talk about in Kenya, for example, about the exclusive breastfeeding. That is something that we come up with is a study of in these groups that we work in Manchai and in Huánuco. We found that the exclusive breastfeeding, the prevalence is very low. And it's different what we have the national survey shows, because it's just a general question. But when you construct and explore very well the practice of exclusive breastfeeding, we got like around 25% of exclusive breastfeeding in these samples. So it's very low, and the stakeholders and all the people who were present at the meeting, they were impressed, no? That it's really low. And actually, looking other previous studies that we have conducted in peri-urban areas, they are showing us that the practice is low. So that is something also that we have to pay attention, because Peru was known as a country where the breastfeeding was okay and it was a good practice and we were the champions. But now with all these the mother working and other activities that they are involved, we are facing now again a work that we have to pay attention. Now we have to pay attention to breastfeeding too again.
It's really interesting the similarities between countries in different continents, the UK as well. And the similarities are there for everyone to see, I'm sure. It's interesting that the solutions are very similar. Kind of the framework around it is there's some education, but I think the key thing with what I'm hearing is understanding the local context, and this kind of co-development type approach seems to be the way that you can overcome these issues through expert knowledge and through local understanding. It seems like you're all battling in the right direction to kind of achieve some amazing things. So it's been absolutely brilliant speaking to you. I think the only question really left from me is, what are the kind of future research plans for you both, really, or for all of you?
Shall I start in Kenya, Martin? Liz and I were actually lucky enough to be together in Kenya last week, and we're talking about this. And I think there are a couple of directions of travel for our future work. And one of them is around the fact that climate change is happening, and climate change is impacting food and food security in Kenya. So one idea is working with communities to think about agroforestry and agricultural practices that can be more resilient to climate change, working in combination with the health services to help to ensure that communities know about the types of foods that they should still be feeding infants and young children. So there's that kind of direction on the climate side, but there's also working forward from the work that Liz did in her international engagement fellowship around kitchen gardening, and the role of kitchen gardening, particularly in urban poor situations, where healthy food availability can be quite poor, and working with communities to improve the availability of fruits and vegetables, particularly through things like kitchen gardening. So Liz, I don't know if you want to add anything there.
Yeah, maybe just to add that, you've said it, just to put into context that actually one of the, as we are improving breastfeeding practices, we still have a major problem with complementary feeding for children under 2 years. And so like for Kenya, it's like under slightly below a third of children are given the minimum acceptable diet. And so that is a major challenge that we have and we need to deal with. And so that's why we want to combine nutrition-specific interventions, which includes like promotion of breastfeeding, but also nutrition-sensitive interventions that provide they deal with the structural issues, and they deal with issues of food insecurity. Yeah, because people tell us that, we tell them about this good feeding of their children, how to feed their children, but where is the food? They ask, especially in urban poor settings. So those are some of the things we are thinking about to promote also complementary feeding, so that eventually children are healthy.
Thanks, Liz. What about yourself, Emily?
Well, in Peru, we'd like to do more work with the health centres, and so just to kind of build those stronger links between caregivers and the advice that they're given when they come in for their regular health checks, and how the health professionals can make the most of those opportunities. But Rossina's also working on some other projects, a bit like the one Paula mentioned about improving community access to affordable foods and supporting initiatives to promote fruit and vegetables and things like that. Rossina, do you want to say a bit about those as well?
Yes, Emily, thank you. Yes, the idea is with Emily is to continue working in this prototype that we come up, and even when we just conducted a pilot, try to do something, like bigger with these prototypes and keep improving them, because these were just prototypes that we ended up in the research. And as Emily said, yeah, we are also, now that we are facing this feeding problem in the community in general for the population, we are trying to work with these common pots that came up during the pandemic. We have a lot of common pots that it's a community organization that have get together the families with mainly the mothers who get together and try to cook for all the communities. So this is called the community common pots, no? And this is there are other ones that are community kitchen. These are organized as they came up like a long time before, and this gets support from the government. So we are trying to help them to get a better choice of food when you have to buy or you have to decide what to prepare. We are working with the communities. Actually, we have conducted a pilot to understand what they are preparing and how we can improve what they are preparing, and giving them options of other food that can be used to improve. Mainly, as I said, vegetable consumption that is very, very low here. And the protein also, trying to give them the ideas of what kind of preparation they can make. So we are now coming up with this. It's called in Spanish it's la mejor compra. In English should be the best buy, no? But for food.
Nice. I won't try and say that in Spanish myself, but it was very good. Guys, I really, really appreciate you coming on, and hopefully our listeners, have got a real good understanding of the work and the research that you're all doing to have impact around the world on kind of global child health and nutrition. And hopefully in a few years' time, we'll see the developments of this. We'll see how this has gone, not just from children. You mentioned habits earlier, and children growing into adults, and the health of adults becoming better around the world. And here's a good vision for you, isn't it? That you can all have that huge impact on not only the prevalence of death with children, but the development of their nutrition and the impacts of that further up the chain. We're having the same or similar conversations in the UK to try and help in those aspects and starting with the child. There's other podcasts that we've done. I know we did one on overcoming fussy eating as part of this series. We did another one on encouraging children's healthy eating through the 3 R's. So we've got a number of podcasts out there, UK based, but it's been really good to look at a couple of case studies from Kenya and from Peru to get a real understanding of the impact of the work that's going on around the world to help health. So really appreciate you coming on. I'm sure some of our listeners might want to get in touch. So if they do, we'll put contact details out on a press release, if that's okay with everybody. And obviously people can get in contact with me and I can share details. So if anyone's interested in finding out more about your research or collaborating with further research, then please get in touch. But for now, we're finished. So much appreciated, everyone. I know time frames and things like that. It's different times for everybody. So thank you. And hopefully we will speak again in the future.
And thanks, Martin, for all your work in doing these podcasts, because I think it's great to have a way of getting the work out to people who, we publish in our academic journals. We go to the community events for the communities we work with, but this is just another way of people finding out about what we do. So, and I know it takes a lot of your effort to do it. So I'm certainly very appreciative, and I'm sure everybody else is.
Yeah, definitely.
No problem. I love doing it. I do love, skimming over your guys' research and really going, wow, you guys do some unbelievable things, and it'd be great to get more and more of it out there. So, thank you to you guys for research. Thank you for you guys for the impact that you're having locally on your communities as well. Incredible stuff that you're all doing. So, I genuinely feel humbled to kind of, talk to you guys. So thank you.
Thanks for listening to the Experts in Sport podcast. If you'd like to get in touch, then please contact me, Martin Foster, at m.foster@loughborough.ac.uk. Thanks for listening. See you next time.